All right, start up. Hi, everybody. My name is Micah Hansen. I'm a medical student here at McMaster, and I'm with my co-presenters today are Kim Wu and Kevin Wren, who are also McMaster medical students. The principal investigator for this presentation is Dr. Carl Stobie. The title for today is Paramedic Care of Injection Drug Users with Soft Tissue Infections in a Safe Injection Site. Next slide. We have no conflicts of interest to declare. Next slide. For introduction, the prevalence of skin and soft tissue infections, or SSTIs as we'll refer to them, can be high among injection drug users and ranges from 6 to 69%. Larney et al. Reported that without treatment, these skin and soft tissue infections in injection drug users can progress to infective endocarditis with a prevalence of 0.5 to 12%, bone and joint infections with a prevalence of 0.5 to 2%, and sepsis between 2 to 10% prevalence. Summers et al. Study of 85 injection drug users with SSTIs reported that 79% delayed seeking medical treatments by 2+ days, and 38% delayed seeking medical treatments by 2+ weeks. When these injection drug users eventually did seek medical treatment for their SSTIs, 49% chose to visit emergency departments, 21% contacted non-medical persons, and 8% contacted primary care practitioners. Furthermore, 32% were reported to take antibiotics not prescribed to them. Next slide. So this is the previous journey for a patient who injects drugs with an SSTI. The first step is that the client who injects drugs has or develops an SSTI. When they develop this infection, they go to the safe injection site where they are initially triaged by a paramedic. But the paramedic at the site can only manage drug overdoses, so the client has to turn either to family physicians or an emergency department to receive treatment. We know from the literature and from anecdotal evidence that very few injection drug users have access to family physicians for their primary care, so most clients with an SSTI turn to emergency departments for their care. Unfortunately, most of the time, they only seek emergency care once they have developed serious complications of the infections. As you can imagine, this leads to an increase in morbidity and mortality from complications. Next slide. So the types of staff working at safe injection sites are mostly those without the ability to diagnose and prescribe treatment. Most of them are nurses and paramedics. The review of the literature also notes that no current examples of paramedics at safe injection sites diagnosing and administering medical treatment for SSTIs. With paramedics on staff, the St. Catharines Safe Injection Site is ideally positioned to examine paramedic care of SSTIs. Now I'm going to pass it off to Kevin.
So the objectives of our study are to determine the prevalence of SSTIs among injection drug users attending a community-based safe injection site in St. Catharines, to create a physician's advance directive for paramedics to assess, diagnose, and prescribe antibiotics to injection drug users with SSTIs, and to measure protocol usage and antibiotic prescription rates at the safe injection site. So the St. Catharines Safe Injection Site has 123 unique injection drug users visiting each month from a catchment area that has a population of just over 140,000. And from February 5th to 21st, 2020, all injection drug users that visited the site were asked to respond to the following 3 questions. In the past 3 months, have I had a skin infection? Yes or no? Do I have a skin infection right now? Yes or no? And am I interested in having someone at the site who would be able to take a look and treat skin wounds infections? Yes or no? In collaboration with the clinical staff, we created an advance directive from the physician to enable paramedics to provide care for SSTIs on site. In terms of our results, the survey was administered to 50 injection drug users, and the responses to 3 questions were as follows. In the past 3 months, have I had a skin infection? With 26% answering yes. Do I have a skin infection right now? With 18% answering yes. And am I interested in having someone at the site who would be able to take a look and treat skin wounds and infections? With 84% answering yes. And the usage of our advance directive was tracked from March to July of 2020. The protocol was used by the paramedic 81 times, and antibiotics were prescribed to injection drug users 11 times.
So this is the new patient journey that we imagine using this proposed advance directive. Now, when a client develops a skin and soft tissue infection, their first site that they go to is still the safe injection site. They're still triaged by the paramedic, but now that paramedic is enabled to provide primary care. First of all, they have the capacity to both diagnose and treat an SSTI, in that they can perform the history and the physical examination, and they have the antibiotics and training to prescribe it. Second of all, they also are trained to identify red flags related to skin and soft tissue infections and to send them to the emergency department. This is all done in consultation with an on-call physician. This physician will review the chart provided by the paramedic and by telephone discuss the case and provide feedback to the paramedic. If necessary, they will change the treatment and communicate that with the client. So as you can see, we have enabled the client to not require accessing the emergency department or primary care physicians as the previous model had. So overall, what we have shown is that the prevalence of SSTIs amongst injecting drug users attending safe injection sites is very high. And this is especially true at the St. Catharines site that we monitor. The new advanced directive for care of injecting drug users with SSTIs was successfully introduced at the St. Catharines site. Now, in our current model, we have one paramedic who is on call for 2 shifts per week at the safe injection site. Our goal is to broaden this such that additional paramedics are trained and we can have one staff there every single day of the week. Furthermore, currently we only have one physician available to consult and review cases with the paramedic. And one potential reason for this is that no OHIP billing code exists to compensate the physician. So it is all done on a voluntary basis. Lastly, determining their adherence to treatment and wound healing is difficult as they access healthcare irregularly and use unreliable means of communication. We want to thank everyone for coming to see our presentation today.